Now, brain tumors is something you'll study repeatedly in pathology, you'll study it in surgery, you'll study a little bit in medicine, you'll study again in radiology here. So what I'm going to try and do here in this particular video for a discussion of brain tumors is that I'm going to create for you a smart work strategy that will give you the highest yield as far as the topic of brain tumors is concerned, but in the minimal possible time and efforts that you put in. So what we will do in this particular session is that we will be following a pattern-based approach. I want you to realize that there are a few handful of important diagnoses which are very frequently asked. So like as in this case, right, this is a frequently asked question in which they give you a history of a child presents with headache and visual disturbance because the optic chiasma is getting compressed. And on a CT or an MR, whatever image they give you, you will be able to see a calcified, see these white dots? A solid cystic calcified lesion where located just above the sella. This is the sella, so this is the suprasellar region. So a calcified solid cystic lesion in the sellar region or the suprasellar region in a child is craniopharyngioma. This is something has been repeatedly asked. So you see a lesion here in a child, you know there's only one possible diagnosis at your exam level. When as radiologists I practice, I have to rule out other DDs as well. But for your exams, you're asked typical things most of the times, and this is what typically the answer is. It is craniopharyngioma. Similarly, see, another location clincher is when you see the pons and the cerebellum, and in between them you see this enhancing tumor on contrast enhanced MR with a specific ice cream cone appearance. This is the most common tumor at the level of the cerebellopontine angle. And what is this? This is acoustic schwannoma. Now they are asking you a question here, not about the diagnosis, but the syndromic association, of brain tumors, and this is a very, very important topic. There are multiple brain tumors which are associated with specific, syndromes, right? And we are going to also discuss this. So bilateral acoustic schwannoma suggests neurofibromatosis type 2. We'll discuss this as we go ahead. Another very classic, a very important topic that is related to brain tumors, because in each of these syndromes a brain tumor is seen, is the topic of neurocutaneous syndromes. Neurocutaneous syndromes is another very important topic, right? And this is one such question. A 12-year-old child, presents with recurrent seizures. Multiple calcified nodules along the ependymal margin are called subependymal nodules. So these subependymal nodules can progress into a cancer. Can it be a acoustic schwannoma? Can it be an ependymoma? It looks like, but no, it progresses into a subependymal giant cell astrocytoma or SGCA. What is this? We'll discuss this. It's associated with tuberous sclerosis. This is something that we are going to discuss in this high yield topic. So first, let us see whether we can try and distinguish between extraaxial brain tumors, that is those located outside the brain parenchyma proper, and intraaxial brain tumors, that is those located within the brain parenchyma. Let us look at the prototype examples. The most common extraaxial brain tumor you must be aware of outside the brain is meningioma. Similarly, the most common intraaxial brain tumors are glioma and metastasis. Which one of these is more common? We'll discuss this as we go ahead. Now, there are certain ways in which we can try and distinguish between extraaxial and intraaxial tumors. Though it appears to be simple, it is not simple sometimes clinically, because there can be a significant overlap between them. But some criteria have been established. Let us look at a few criterions. A meningioma or an extraaxial lesion will always have a broad base like this towards the dura. So broad base towards the dura is a feature of extraaxial lesion. It is not seen in intraaxial lesions. Dural tail, similarly, this meningioma always has a tapering tail like this towards the dura because it is arising from the dura. So dural tail is also a feature of extraaxial lesions. It is not seen in intraaxial tumors. CSF cleft, now watch carefully, because the tumor is outside. What it will do, it will create a mass outside the brain. It will push the brain inwards, but in between them, in between the tumor and the brain, there will be a cleft of CSF which is there. If you look at this particular image here, this hyperintense area here is that thin cleft of CSF which is seen, and therefore a CSF cleft being seen is again a feature of extraaxial tumor. It is never seen in intraaxial tumors. Similarly, cortical buckling, that is the cortex being pushed inside like this. As you can see, here is a feature of extraaxial because it is going to push the brain parenchyma inwards. This is not seen in intraaxial tumors. Also, along with the cortex, the vessels running along the surface of the cortex will also be displaced in extraaxial tumors. This will not be seen in intraaxial tumors. Now, with this in mind, let us look at certain location clinchers. What are location clinchers? I will tell you and I will show you that there is a tumor at a peculiar location in the brain. And then when there is a tumor there, you should think of only a few handful of diagnoses, right? Out of which the most common ones we will discuss in detail here. That is how, just by looking at an image and realizing that there is a tumor at a particular site, right, you will be able to narrow down to a set of differential diagnosis and pick up the most common one. So now we start with the area which is called cerebellopontine angle. So this is pons. This is the right lobe of the cerebellum. This is the left lobe of the cerebellum. In between the pons and the cerebellum, this area here is called as the cerebellopontine angle. Here in this patient, you see a large enhancing lesion in the cerebellopontine angle which has a small extension like this. So this area is where this is the cerebellopontine angle. What are the tumors which are found to be seen in the cerebellopontine angle? The most common tumor here is acoustic schwannoma. Schwannoma or vestibular schwannoma. The second most common tumor here is usually a meningioma. Remember, it's usually a meningioma. It could also be, at this site we can also see a epidermoid cyst or also a arachnoid cyst. These are different entities, but both of them are cysts. Epidermoid cyst or arachnoid cyst can also be seen. Sometimes dermoids can also be seen. But for your exam level, what is most important? You must remember acoustic schwannoma and meningioma. How to differentiate between them? Very easy. If you see a tail, this extension into the internal acoustic meatus, it means that it is spreading along the vestibular nerve. Therefore, it is arising from the vestibular nerve, and that is a feature of acoustic schwannoma. Yes. Now look at this particular tumor in the right cerebellopontine angle. Look at the appearance. Can you see? This appearance is called ice cream on cone appearance. What is ice cream on cone appearance? See, the chunk of the ice cream is formed by the mass bulk of the tumor within the CP angle, but can you see the cone is formed by a small extension of this particular tumor along the vestibular nerve in the internal acoustic meatus. So this is what creates the ice cream cone appearance typical of an acoustic schwannoma or a vestibular schwannoma. This we have discussed is the most common tumor at the cerebellopontine angle, right? It usually arises along the inferior vestibular nerve. If you see bilateral acoustic schwannomas, then it is associated with neurofibromatosis type 2. This was the syndromic association question which was asked. Ice cream on cone appearance we have seen. It is also showing intense enhancement. Yes, so this is about acoustic schwannoma or vestibular schwannoma. Now, if you come across tumor around the cellar or paracellar region. Now, if you see, this is the clivus, this is the sphenoid sinus, and in the sphenoid bone is the sella. So this is the sella. Can you see that there is a tumor which is arising from the sella, but it is not restricted to the sella. It is extending above it, and it is creating a 8-like appearance or a snowman-like appearance. See, again the tumor is arising from the sella, it is extending above the sella, right, and it's creating a snowman-like appearance. The most common tumor in the cellar paracellar region in adults, remember, you expect a pituitary adenoma. Most likely it is a macroadenoma. What is a macroadenoma? What is a microadenoma? We'll discuss it. But if the history is of a child, then remember that the most common lesion here in a child, right, in the paracellar region or the supracellar region is a craniopharyngioma. Just by looking at the site of the tumor and the age group, you are able to get a diagnosis. This is the most common question that it is likely that it will be asked to you in your exam, right? At this site, there are other tumors which could also be seen. It could be a meningioma here, a Rathke's cleft cyst, could also be seen at this particular site. Other tumors like germinoma, dermoids, epidermoids can also be seen. It could be a germinoma, it could be a dermoid or a epidermoid cyst, which could also be seen. So these are the tumors you should expect to see in the cellular paracellular regions, right? Now we come to a very classical, rather the most common tumor in the cellular paracellular region in adults. Most common tumor in adults, where at the cellular paracellular region. Why is it is the pituitary macroadenoma? Why is it called macro? Because it is more than 10 mm in size. Now when it extends beyond the cella, it is the diaphragma cellae, right, which covers the cella, which actually creates a constriction in its middle part, and that is the reason why it appears like a figure of 8 or a snowman like this. It appears like a figure of 8 or a snowman like this. This is what gives it a name. This is what is called as the figure of 8 sign. The figure of 8 sign or snowman appearance, or snowman appearance of the pituitary macroadenoma. Now because it grows up, it creates a mass effect on the optic chiasma. So there are visual defects. Usually the central fibers are affected. So typically there is bitemporal hemianopia. Bitemporal hemianopia, right? So this is what is pituitary macroadenoma. Usually because it arises from the pituitary gland, the pituitary gland cannot be separately identified. It also shows intense enhancement. A transsphenoidal excision of the macroadenoma can be attempted in such cases. Now if there is a very small adenoma, it is called microadenoma if its size is less than 10 millimeters. A specific technique is required for its diagnosis because its enhancement pattern is different. What is that technique? It is called dynamic contrast enhanced MRI. So dynamic contrast enhanced MRI is used for a diagnosis of pituitary microadenoma. Now multiple, so the contrast is injected using a pressure injector very rapidly, and once the injection of contrast is done, right, these images are constantly acquired for a certain duration of time. Why? Because the enhancement pattern of the tumor and pituitary gland is different. If you look at this particular image here, this is the tumor. Can you see that the tumor is appearing slightly hypo-intense or dark as compared to the rest of the pituitary gland? Yes. So what is the enhancement characteristic of a pituitary microadenoma? It usually enhances less than the normal pituitary gland. So a pituitary microadenoma usually enhances less as compared to a normal pituitary gland, right? So this is what is called as a pituitary microadenoma. These are the specific features associated with it. Now we discussed the most common lesion found in the cellular paracellular region in children is what? It is craniopharyngioma. So craniopharyngioma, though I have said it is commonly seen in children, craniopharyngioma actually has two peaks related to age of presentation where it can present. Firstly, it can present between 10 to 14 years, and this is the most common way, or this is the most common presentation pattern of craniopharyngioma. Or it could also sometimes present more than 50 years. Remember, craniopharyngioma is a C. So craniopharyngioma is seen in what? It is seen in children. It is a partially cystic lesion, and it always shows central calcification. So if you see a calcified cystic mass in children in the cellular paracellular region, what is the diagnosis? There is only one possible diagnosis at your level, and that is craniopharyngioma. So it is a solid cystic calcified mass in the cellular region, in the supracellular region in children. Because it again impinges on the optic chiasma, it can give rise to bitemporal hemianopia as well. So this is about craniopharyngioma. As you can see in this particular CT image, right, this is the cellular area where you can see this calcified mass. In a coronal reconstructed image, you can see this large cystic solid component there, right? See there, the cella is normal. It is located mainly in the supracellular region. So this is what is craniopharyngioma. Yes. Now if you see a tumor occurring within the ventricular system, this is again a very specific site, right? So usually these tumors include ependymoma, right, medulloblastoma. Ependymoma and medulloblastoma mostly are seen in or around the fourth ventricle, and we'll see these as we go ahead. So ependymoma, medulloblastoma, it could be a central neurocytoma, central neurocytoma. It could be a subependymoma. This could be a subependymoma. It could be a colloid cyst. Choroid, so it could be a colloid cyst. It could be a choroid plexus papilloma. Choroid plexus is located where? It is located in the ventricular system. So it could be a choroid plexus papilloma. It could be a subependymal giant cell astrocytoma. What is this? We'll discuss this. Though medulloblastoma is not actually intraventricular, remember, it is in close relationship to the fourth ventricle, right? Now let us look at this tumor. What is this tumor? This tumor is a very bubbly appearing tumor. See why? Because there are multiple cystic spaces within it. It is located where? It is located in the body of the lateral ventricle here. Can you see? Close to the septum pellucidum here. So this is the septum pellucidum in the midline. It is closely related to the septum pellucidum. So this is a very typical location of a tumor which is called central neurocytoma. It is usually seen in adults in around 20 to 40 years age group. It is located in the body of the lateral ventricles. It has multiple cysts, so it appears bubbly. It is usually closely attached to the septum pellucidum. So this also leads to hydrocephalus. This is the central neurocytoma. Now another very typical appearance is the presence of subependymal nodules. See, along the ventricular system, along the ependymal margin, you are able to see these multiple subependymal nodules. These subependymal nodules are pathognomonic for one particular neurocutaneous syndrome, and that is tuberous sclerosis. Tuberous sclerosis. Now, these subependymal nodules may progress to a tumor. They don't progress to an ependymoma, but they usually progress to a subependymal giant cell astrocytoma. A subependymal giant cell astrocytoma. See, here one of the subependymal nodules has become very large, and this is a tumor which is subependymal giant cell astrocytoma. So a subependymal nodule usually progresses to this tumor, subependymal giant cell astrocytoma. Both of these are therefore features of tuberous sclerosis. Remember, yes. Now, an intraventricular tumor could also be a colloid cyst. This is very typical. This is a clincher. Why? Because it is located at the level of the foramen of Monro. Can you see? A hyperdense lesion on non-contrastivity. Why? Because it is full of mucin, dense content of mucin, and therefore it appears hyperdense. Therefore, on T1 weighted image, again, it is located in the region of foramen of Monro. Where it is located? It is located at the foramen of Monro, and it is appearing hyperdense on CT. It contains mucin, so it also appears hyperintense on T1 weighted images. Hyperintense on T1 weighted images. It creates an obstruction to the flow of CSF. It is at the foramen of Monro, compresses it, so lateral ventricles, they get dilated. Usually complete surgical excision is the treatment. So because they cause hydrocephalus, presence with headache, so all these are very typical features of colloid cyst or a paraphyseal cyst. A colloid cyst is also called as a paraphyseal cyst. Yes, so paraphyseal cyst. So this is what is a colloid cyst. Now, if we come to fourth ventricular tumors, intraventricular or fourth ventricular tumors, they are very commonly seen in children. Remember, so in children, in and around the fourth ventricle, there are multiple tumors which are seen. The most common one that is seen is called as a pilocytic astrocytoma. Right, this is the most common one. Pilocytic astrocytoma may present as a cystic lesion with an enhancing mural nodule. It is a type of brainstem glioma which projects into the fourth ventricle. Other tumors here usually include medulloblastoma, which is a very aggressive tumor, an ependymoma, a subependymoma, or an exophytic brainstem glioma. Now, if we look at this particular tumor, this is a pilocytic astrocytoma because, see, it is very closely related to the fourth ventricle, almost projecting into the fourth ventricle, appearing hypointense on T1, hyperintense on T2, and it is showing very minimal enhancement. So, very minimal enhancement. That is because it is actually a low-grade glioma. What is this? This is a low-grade glioma. So, this is a low-grade glioma, shows variable, enhancement pattern. Very commonly, this also presents as a cystic lesion with a mural enhancing nodule. Mural enhancing nodule. So in a child, if you see a cystic lesion with a mural enhancing nodule around the fourth ventricle, then your diagnosis you should be thinking of is pilocytic astrocytoma. Another tumor which is seen around the fourth ventricle, two important tumors we should discuss because we are going to discuss the differential diagnosis between them. One of them is ependymoma, the other one is medulloblastoma. So ependymomas, remember, occurs in children when it is usually occurs in the second decade of life. Remember, slightly later. Medulloblastoma appears slightly earlier in the first decade. Ependymoma appears slightly later. Most commonly it occurs around the fourth ventricle. It is a plastic tumor. What is the meaning of a plastic tumor? Plastic tumor means it is very flexible. Whatever place is available, it will fill that space and it will ooze out. So fourth ventricle opens by the foramen of Magendie and Luschka. So it can actually extend through the foramen of Magendie and Luschka and it could enter into the basal CSF spaces. Right? One important parameter to look at a fourth ventricular tumor is whether it is arising from the floor of the fourth ventricle or the roof. Here the margins of the tumor in relation with the floor are very indistinct, so it appears as if it is originating from the floor of the fourth ventricle and projecting and distending the roof. So therefore, remember, ependymomas always arise from the floor of the fourth ventricle. They arise from the floor of the fourth ventricle. Now, in contrast to this, now they are showing uniform enhancement, right? Multiple, intense enhancement it is showing. Now, in contrast to this, let us compare it with medulloblastoma. Medulloblastoma is a very aggressive tumor. It is, remember, a WHO grade 4 tumor. It is also called PNET-MB. What is PNET-MB? It is primary neuroectodermal tumor. It is primary neuroectodermal tumor. So primary neuroectodermal tumor. Now it arises primarily from the roof of the fourth ventricle. Remember, so there is a clear plane which is visible between this tumor and the floor of the fourth ventricle. See, so it is arising from the roof of the fourth ventricle. It is an aggressive tumor. Why? Because it can show CSF spread. So it can show CSF drop metastasis. So from here it can drop down and create a deposit along the spinal cord. This, when you give contrast, it enhances. This look like cake icing like deposits. This is given a name. This is what is called as Zuckergus. What is Zuckergus? Zuckergus is nothing but these cake icing like metastatic deposits along the surface of the spinal cord due to CSF dissemination. So in this medulloblastoma cases, craniospinal irradiation is used as a management strategy because this particular tumor is a very aggressive tumor. Now we have just discussed about ependymomas and medulloblastomas, right? Let us try and distinguish between them. One of the most important ways to try and distinguish between them is to look where they are arising from. So ependymomas, they usually arise from the floor of the fourth ventricle, as you can see here, right? Whereas medulloblastomas, they usually arise from the roof of the fourth ventricle, so a classic plane is seen at the floor. Remember, ependymomas are usually seen in the second decade of life, so slightly later, whereas medulloblastomas are usually seen in the first decade of life, slightly younger children. So this is what is about ependymoma versus medulloblastoma. Now let us come to one of the most important tumors that I want you to know, and therefore you must know everything about this particular tumor. This is a meningioma. Meningioma, remember, is the prototype extraaxial lesion, right? It is the most common primary non-glial tumor. It is seen in what age group? It is seen mainly in the middle age group or middle-aged females. So middle-aged females, it is mainly seen. So middle-aged females, it is more commonly seen. It is in this particular age group, right? It has peculiarly, remember, meningiomas can have progesterone receptors. Progesterone receptors, and therefore if a young female has this particular meningioma, if the female is pregnant, it can significantly increase in size in pregnancy. It can increase in size in pregnancy. So because they have progesterone receptors, this can happen. Now see where it is there. Now it is always where it is located. It's located always close to the meningeal surface. So either along the hemispheres or along the falx cerebri, which is a meningeal layer. So it has common locations. One of the most common locations is parafalcine. Parafalcine in location. It is also seen in the CP angle because there is meninges which are there. So it is close to the meningeal surface always because it arises from the meningeal surface. So it is central parasagittal portion region or the parafalcine region along the falx is one of the most commonest locations. Now if you look at the findings that you see here in this particular image, this is a post-contrast MR image. Do you remember we discussed various parameters, to try and distinguish between an intra and an extra-axial lesion, right? Meningioma is extra-axial, it is outside the brain, right? So one of the first points that we discussed in favor of an extra-axial lesion is this broad base towards the dura. Can you see? There is a broad base towards the dura. So what is this? This is a broad base towards the dura. Okay. Then if you look at the lateral aspects where the tumor actually ends, look at these blue arrows. Can you see these tapering tails here? Right. So what are these? These are called as the dural tails. These are called dural tails. So these are all peculiar features of meningioma. Broad base towards the dura, dural tails, right? These are the tapered portions and it is showing intense enhancement. So how is it enhancing? It is showing intense enhancements, right? So intense enhancement on post-contrast study. So these are few important features related to meningioma. Another feature of meningioma is that it appears hyperdense or white on non-contrast CT as well. See, this is the normal brain. As compared to the normal brain, can you see this tumor? It is appearing hyperdense or bright. It has a broad base towards the dura. It is also showing intense enhancement. It is also showing intense enhancement on post-contrast CT there, right? Because it is located close to the dural surface. Remember, meningiomas are also associated with hyperostosis of bone. These are all peculiar features I want you to know. So they are associated with hyperostosis, thickening of the bone. They are associated with dilatation of adjacent paranasal sinuses. If it is in the basifrontal area, it will be associated with enlargement of the frontal sinus. This is given a name. This is called as pneumosinus dilatans. Pneumosinus dilatans. So hyperostosis, it is associated with hyperostosis of bone, pneumosinus dilatans. And here we have seen that it is appearing hyperdense on non-contrast CT. Now there are few tumors that can appear hyperdense on non-contrast CT. We have seen one here, that is meningioma. If you remember, we have seen a colloid cyst at the foramen of Monro, isn't it? Which I told you it contains mucin, so it appears hyperdense. Few other tumors also appear hyperdense or bright on non-contrast CT. These include medulloblastoma. These include certain types of lymphomas. Colloid cysts we have already seen. Certain types of metastasis can also appear hyperdense on non-contrast CT. So most important, remember, meningioma, colloid cyst, medulloblastoma. So these appear bright on non-contrast CT. Few more associations with meningioma include that what are their blood supply. Remember, a meningioma is supplied by both the vessels of internal carotid artery as well as external carotid artery. What branches of internal carotid artery? These are the pial vessels, right? That supplies the pia mater. The pial vessels, these usually, supply the peripheral portions of meningioma, whereas the branches coming from middle meningeal arteries, they supply the central core of the meningioma. Yes. Now on angiography, they show a very typical pattern on angiography, right? These vessels get opacified. This gives rise to a spoke wheel pattern. This gives rise to a spoke wheel pattern or a sunburst appearance. Sunburst appearance. So spoke wheel pattern or sunburst appearance is seen on angiography. Now another finding which is seen on angiography is what is called as the mother-in-law sign. What is the mother-in-law sign? Right? It states that because it has so extensive vascularity, what happens in meningioma is that the contrast on angiography, it comes in early, right? It comes in early and fills up the meningioma, right? But it does not leave early, so it stays for long in the meningioma. This is been described similar to having a mother-in-law, where they say that the mother-in-law comes in your life quite early and then doesn't leave early. So that is what is called as that is what is called as the mother-in-law sign. Come on, you're not supposed to say like this about your mother-in-law, but somebody naughty, somebody courageous has coined this term in the radiology books. I am not saying it, they have said in the book there. That is what is called as the mother-in-law sign. Now, meningioma is also associated with a specific finding on MR spectroscopy. What is MR spectroscopy? It gives us the chemical composition at a particular site, and meningioma therefore gives rise to a specific chemical peak in at that particular site, and this is an elevated, remember, this is an elevated alanine peak. This is an elevated alanine peak which is seen in MR spectroscopy at 1.4 ppm, right? So this is an elevated alanine peak, which is very, very important. I want you to know about meningioma. Now, another syndromic association of meningioma is what is Miss-Me syndrome. What is Miss-Me syndrome? It is neurofibromatosis type 2, right? So what is this? Multiple inherited schwannoma, meningioma, and ependymoma. Schwannoma, meningioma, and ependymoma, right? This is what is Miss-Me syndrome. So that is the syndromic association with meningioma. Now look at this. This bracket-shaped calcification. So this is another factual question which was asked previously in the olden days. Now they'll show you an image. Look at this image. In this CT image, what you see is the central fat density, because it is appearing severely hypodense, surrounded by a bracket-shaped calcification around it. This is called this bracket-shaped calcification because this is fat density. It is seen in what? It is seen in corpus callosal lipoma. The corpus callosal lipoma can occur in two forms. One can be a curvilinear form along the splenium of the corpus callosum, or it can be a tubulonodular form. So this is that tubulonodular form, right, in which there is a bracket-shaped calcification which is there. So this is bracket-shaped calcification seen in corpus callosal lipoma. Now let us quickly discuss the commonest or most commonest as far as intraaxial tumors are concerned. So in children, remember, the most common intraaxial tumor is a astrocytoma. Remember, the second most common intraaxial tumor is a medulloblastoma, and the third most common intraaxial tumor is a ependymoma. Right, so this is for children. In adult, the most common overall, right, intraaxial tumor is metastasis. But if they specifically ask you, right, what is the most common primary tumor within the brain, then remember these are gliomas. Now there's a little bit of controversy in certain books which say that meningioma is the most common, but I want you to be aware here, most of the standard books say that it is the gliomas which are the most common primary brain tumor. Okay. Now let us look at gliomas. Now how do you grade these gliomas? Now there is a WHO grading, right, which classifies them into grade 1, 2, 3 and 4. What changes, right, when you go from grade 1 to grade 2? So grade 1 tumors are usually localized. They are usually localized astrocytomas. Localized astrocytomas are usually grade 1 tumors, whereas grade 4 tumors are extremely aggressive tumors. So they are aggressive tumors like glioblastoma. Now what changes therefore when we go from grade 1 to grade 4? As we go from grade 1 to grade 4, the enhancement of the tumor increases. The enhancement increases. Along with this, the necrosis also increases. And because the aggressiveness is increasing, the enhancement is increasing, necrosis is increasing, the overall survival decreases as we go from grade 1 to grade 4. Now in this, you will be asked certain specific types of tumors, and therefore we will be discussing them. The most common one is glioblastoma multiforme or GBM. This is WHO grade 4, the most aggressive type of glioma. Now according to the recent terms, this word multiforme is dropped, so it is just called as glioblastoma or a grade 4 glioma. Now see here, look at this contrast enhanced MR image. What do you see here? This is right, that is left. This is an intraaxial intensely but heterogeneously enhancing intraaxial mass lesion. What do you see in the central area? The central area is not enhancing, isn't it? Why is it not enhancing? Because central area of necrosis is a radiological as well as a pathological hallmark of glioblastomas. There is always a central area of necrosis. This is a hallmark. Around the central area of necrosis, there is a peripheral irregular rim of enhancement, very thick layer, irregular dirty enhancement which is seen around it. Usually, glioblastomas is seen in the elderly age group, say around 45 to 65 years. So usually it is seen in the elderly age groups. It can have drop metastasis. It is associated with certain syndromes. One such syndrome is called as Turcot syndrome. What is the association of Turcot syndromes? In Turcot syndrome, along with a brain tumor, there are multiple intestinal polyps. So this is what is the association with Turcot syndrome. Now another peculiar feature in which it can appear is what is called as a butterfly glioma, because it is a very aggressive, very invasive tumor. It starts in one cortex, in one hemisphere, but then it extends across the genu of the corpus callosum, right, to the other. So this is what is called as a butterfly glioma. It is a very high grade glioma, grade 4 glioma, most commonly the frontal lobes, and then crosses through the genu. It has extremely poor prognosis. Now, a relatively a glioma, low grade glioma with a better prognosis is oligodendroglioma. Now, look at this CT image here. What do you see? This is right, this is left. Where is the tumor located? The tumor is located superficially along the surface of the brain. So, where is it located? It is cortical in location. First most important thing about this tumor, right? These are all clues about oligodendroglioma. What are these? It is cortical, more or less cortical or subcortical in location. Next, what do you see inside the tumor? What are these dense white areas? Do you realize it is appearing as bright or as dense as bone? Why? Because inside the tumor there is calcification, and therefore remember, this calcification of this tumor is a very peculiar feature. In fact, this is the most common intracranial tumor to calcify, that is oligodendroglioma. Next, it is usually seen in what age group? Glioblastoma is seen in the elderly age group. This tumor, or oligodendroglioma, is seen in the middle-aged patients. So see, a middle-aged patient presents with a cortical subcortical lesion with intense calcification within it. This is very typical of an oligodendroglioma. These are usually well-defined, or these are usually well-differentiated tumors. They have a better prognosis, most commonly located in the frontal lobes, as you can see here. So this is about oligodendroglioma. If you see a tumor within the orbit, right, within the eyeball, it is retinoblastoma, which is the most common intraocular tumor. It is the most common intraocular tumor. It affects children. A child usually presents with the white ocular reflex, so that is called as leukocoria. Right, so this is something which presents as leukocoria. A question has been asked on retinoblastoma as to what is the investigation of choice for a staging of retinoblastoma. The investigation of choice for staging of retinoblastoma is usually considered to be MRI, because it shows us the extent of the tumor very well. Right, there is something which is called as a trilateral retinoblastoma. Trilateral retinoblastoma is a combination of bilateral retinoblastoma plus a pineoblastoma. So this is what is called as a trilateral retinoblastoma. Now look at this specific clinical situation. A 14-year-old male, so a adolescent male, right? Adolescent male presents with what? Presents with epistaxis, nasal blockade. If an adolescent male presents with epistaxis and a mass lesion, you should think of one diagnosis. This is that diagnosis. What is this? This is juvenile nasopharyngeal angiofibroma. It is seen only in adolescent males who will present with epistaxis, because see, juvenile nasopharyngeal angiofibroma, it is a very vascular tumor. Where does it arise? It is basically centered at the sphenopalatine foramen. It is basically centered at the sphenopalatine foramen, which is somewhere over here. From here, the tumor extends into the nasal cavity, so it creates epistaxis. It extends into the infratemporal fossa, right? It extends into the cranial cavity as well. So it shows intense enhancement because it is a vascular tumor. So remember, this is a very specific clinical situation. Now when this tumor basically extends into the infratemporal fossa, what it can do is, here in this image the tumor is actually extending into the sinus, but sometimes it can push the posterior wall of the maxillary sinus anteriorly. This is given a name. This is what is called as the Holman-Miller sign seen in juvenile nasopharyngeal angiofibroma. Holman-Miller sign is what? When this tumor extends into the infratemporal fossa, it actually pushes the posterior wall of the maxillary sinus anteriorly. So this is what is called as the Holman-Miller sign. Because it is, very vascular, it gives rise to a very typical salt and pepper appearance of fluids on MRI. So it gives rise to very typical salt and pepper appearance. Now because it is vascular, right, when you have to treat it surgically, if you directly attempt to treat it, it will bleed, like anything. Patient may lose his life. So to avoid this, there is always a pre-operative embolization of the tumor which is done. So pre-operative embolization of the tumor is done so that the blood supply to the tumor is cut off. The internal maxillary artery is the most common, artery supplying it. So the blood supply is cut off. It becomes an avascular surgical field, and then the tumor can be easily excised. So this is about juvenile nasopharyngeal angiofibroma, right? The maxillary artery, internal maxillary artery is the most common artery which supplies it. Yes. Now look at this clinical scenario. Elderly male, known case of CA lung, presents with altered sensorium, confusion, seizures, and what do you see on contrast MR? You see multiple heterogeneously enhancing lesions. See, there is a lesion here, there is a lesion here, there are multiple lesions here. So these are brain metastases. Now these are discrete masses, usually present at gray-white matter junctions, as you can see in this particular image. Right, the primary tumor is most commonly lungs, or it could be breast cancers as well. Right, now melanoma metastasis, now if it ever goes to the brain, now melanoma has melanin which appears bright on T1. So very specific feature of melanoma metastasis is that these deposits will appear hyper intense or bright on T1 weighted images. So melanoma mets will appear bright on T1 weighted images because of the melanin pigment that they have within it. So elderly patient with a known case of primary cancer, presents with confusion, multiple enhancing lesions in the brain, is brain metastasis. Now we come to the very important topic about the syndromic association along with brain tumor. So what are these syndromes? Let us start with neurofibromatosis type 1. Now everything about these syndromes, the genetic association, various manifestations, we'll study more in pediatrics. Here we'll quickly discuss which tumor is associated with what particular syndrome. So neurofibromatosis type 1 is mainly associated with optic gliomas, optic pathway gliomas. Along the optic nerve, you see a lesion here. See, if you look at these images, this is a T2 weighted image. See this fusiform tumor. See, it is appearing bright on T2. It is appearing slightly iso-intense or hypo-intense on T1, and on post-contrast study, it is showing intense enhancement. That is on the left side. So these are this is an optic nerve glioma, which is a most commonly associated tumor with neurofibromatosis type 1. Peripherally, you will find along these patients' body there are multiple neurofibromas. So it is associated with plexiform neurofibromas, pleximum neurofibromas, all along the body surface in neurofibromatosis type 1. It can also be associated with brainstem gliomas. It is associated with skeletal deformities, especially kyphoscoliosis involving the spine, kyphoscoliosis. Along with that, there is also posterior vertebral scalloping. Means you look at a vertebral body from the sides, it should appear like this. This is how the posterior elements are. But if you see a vertebra in neurofibromatosis, then it has an appearance in which the posterior vertebral body appears scalloped like this, right? From posteriorly, this is how the posterior elements will be. So this is what is called as the posterior vertebral scalloping along with kyphoscoliosis. So this is optic nerve glioma that we have seen. Now see, a very peculiar appearance here is, if you look at the orbits, through the orbits, you can see the two wings of the sphenoid bone. This horizontal bone, now this is the normal right side. This is called as the lesser wing of sphenoid. This is called as the greater wing of sphenoid. See, on the left side, which is grossly abnormal, the orbit is large. You do not see the greater wing of sphenoid. The lesser wing of sphenoid may be here. It is not well identified, but greater wing of sphenoid is absolutely not seen. So the absence or dysplasia of the greater wing of sphenoid makes this orbit appear bare. So this is what is called as the bare orbit sign. So this is sphenoid wing dysplasia. Basically, greater wing of sphenoid is not developed, right? This is also clinically associated with Lish nodules, which are ocular iris based nodules. It can associate with cafe au lait spots. So these are all associations with neurofibromatosis type 1. Most common tumor is optic nerve glioma. Yes. Now we come to neurofibromatosis type 2. See, this is very peculiar appearance. Do you remember this? We have seen pons, cerebellum, and an ice cream on a cone appearance. Can you see that? So ice cream on a cone appearance suggests what? It suggests bilateral acoustic schwannomas. Bilateral acoustic schwannomas. And bilateral acoustic schwannomas are associated with what? They are associated with neurofibromatosis type 2. Just to revise, it is called as Miss-Me syndrome. What is Miss-Me syndrome? It is multiple inherited schwannoma, that is acoustic schwannoma you see here, meningioma and ependymoma. Multiple inherited schwannoma, meningioma and ependymoma. So this is neurofibromatosis type 2. Now another typical syndrome is called von Hippel-Lindau syndrome. One way you can apply the mnemonic secret is to remember the various components of von Hippel-Lindau syndrome by a mnemonic of Hippel. So what are the various conditions which are seen in von Hippel-Lindau syndrome? The first and most important one, remember, is the hemangioblastoma. Hemangioblastoma involving the cerebellum. Along with cerebellum, it could also involve the spine, it could also involve the retina. There is an increased risk of RCC, renal cell cancer. There are multiple pancreatic abnormalities or pancreatic cysts which could be seen, pancreatic lesion cysts, pancreatic cancer, pancreatic cyst adenomas. There could be pheochromocytomas. Epididymis may be involved. So epididymal cyst adenoma, so papillary cyst adenomas, epididymal papillary cyst adenomas, and there are multiple cysts involving the liver, spleen and the few other organs. So what are features which are seen in von Hippel-Lindau? Hemangioblastomas of the cerebellum, increased risk of RCC, pancreatic abnormalities, cysts, cancers, cyst adenoma, other masses, pheochromocytomas, epididymis involvement, papillary cyst adenoma, right, and liver and spleen cysts. These are features which are associated with von Hippel-Lindau syndrome. Now tuberous sclerosis, we have seen these images before. Tuberous sclerosis is associated with these calcified subependymal nodules, and I told you that this progresses to a tumor. What tumor it is? It is a subependymal giant cell astrocytoma, right? So see here, these are, now in this CT image, the calcified tubers that you are able to see here along the subependymal surface, right? Now these are cortical tubers, so the blue arrows are pointing to cortical tubers which are involving, right? Along with this, these white arrows, some white matter signal abnormalities are also seen, right? So these are also white matter abnormalities which are there, right? Subependymal nodules are also visible along the ventricular surface. If you see here, this nodular pattern which is there, these are all subependymal nodules also seen on MRI, and this can progress to subependymal giant cell astrocytoma. It is actually a multicystic involvement. So this is associated also with renal lesions. Tuberous sclerosis is associated with renal lesions, especially in kidney. There are angiomyolipomas, renal cell cancers or renal oncocytomas which are also seen. Now in the lungs, there is lymphangiomyomatosis or LAM involving the lungs. These are multiple cysts which are seen within the lungs, and this can in fact even be detected antenatally when there are certain cardiac tumors which are detected in the fetus. These are called as rhabdomyomas. These are called rhabdomyomas, right? So these are the various features associated with tuberous sclerosis, remember. Now look at this clinical scenario. A 1-year-old male child presented with a very typical port wine stain on the upper face. This port wine stain is usually along the V1 or the ophthalmic division of the trigeminal nerve. There are refractory seizures because there is grossly something abnormal in the brain, and developmental delay with visual disturbances because there is retinal detachment. Choroidal angiomas are also seen. What do you see in this particular image? There are multiple subcortical calcifications, and therefore there is cortical atrophy which is there, and most importantly there are pial angiomas. Can you see this serpiginous enhancement pattern which is there? This is a very peculiar feature of Sturge-Weber syndrome. So remember, right, you see this port wine stain, cortical atrophy, calcification, and pial angiomas. This is very typical of Sturge-Weber syndrome. There are various appearances because this cortex gets calcified on X-rays. This can give rise to a tram track appearance. So this can give rise to a tram track appearance on X-ray of this culvert. It is of course showing intense enhancement as you can see in this particular MR image. So this is suggestive of Sturge-Weber syndrome. Now look at this particular question. Radiological features of neurofibromatosis type 1. We have discussed this in detail. So see, is there posterior scalloping of the vertebral bodies? Yes, this is a diagram that we just drew and I showed you. Is there sphenoid wing dysplasia? Yes, mainly involving the greater wing of sphenoid. Is there narrowing of the neural foramina? No, that is not seen, right? We have not discussed this. Is there kyphoscoliosis? Yes, it is seen. Is there microcephaly? No, we did not discuss this. So what is seen in NF1 is posterior scalloping, sphenoid wing dysplasia, and kyphoscoliosis. This is something that we have seen. So what are the important clinical insights that we get from this discussion? Let us quickly revise in the next 2 to 3 minutes before we stop. What is the overall most common tumor, brain tumor in adults, right? It is metastasis to the brain. Most common primary brain tumor in adults is glioma. Second most common primary brain tumor in adults is a meningioma, which is also the most common non-glial tumor, right? So it is also the most common non-glial tumor. Most common intracranial tumor to calcify. Do you remember I showed you a big calcified tumor in the left frontal cortex? What was that? It is oligodendroglioma. Oligodendroglioma is the most common intracranial tumor to calcify. So few factual, this is just revision of what we have already studied. What is the most common brain tumor in children? It is a pilocytic astrocytoma. Right? Second most common brain tumor in children is a medulloblastoma. Third most common brain tumor is ependymoma. Right? Most common posterior fossa tumor in children again is pilocytic astrocytoma. Okay. Now see, most common tumor at the cerebellopontine angle. Do you remember we have discussed? It is a acoustic schwannoma. Right? Most common type tumor at the suprasellar cistern, but in children we have discussed is craniopharyngioma. Right? Most common tumor in the suprasellar cistern in adults is a pituitary macroadenoma. Right? These are the location clinchers that we have discussed. Let us quickly revise syndromic association because very frequently a question has been asked on this. Meningioma is associated with what? Meningioma is associated with neurofibromatosis type 2, that is multiple inherited schwannoma, meningioma, and ependymoma, Missme syndrome. Glioblastoma is associated with what? It is associated with Turcot's syndrome. Optic nerve glioma is a feature of neurofibromatosis type 1. Subependymal giant cell astrocytoma. We have discussed subependymal nodules progress to subependymal giant cell astrocytoma in tuberous sclerosis. Hemangioblastomas of the cerebellum, of the retina, of the spine is a very common feature of von Hippel-Lindau syndrome. And again, acoustic schwannoma, bilateral acoustic schwannoma is associated with neurofibromatosis type 2. So these are important syndromic associations. So what is this tumor now? See, 9-year-old child presents with headache, visual disturbance, bitemporal hemianopia. You see in the suprasellar region, you see a calcified solid cystic mass. In children, it is C, it is craniopharyngioma. That is going to be the answer here. See, again, we have seen this pons, cerebellum, ice cream on a cone appearance on both sides, Both bilateral acoustic schwannomas is a feature of neurofibromatosis type 2. Multiple times we have discussed this, we have revised this, and again these are subependymal nodules which are calcified, which will give rise to subependymal giant cell astrocytoma. So this is tuberous sclerosis, and this will lead to subependymal giant cell astrocytoma. So I hope you have liked this pattern based approach. This is how, by putting in a minimal amount of time, minimal efforts, you'll be able to solve almost all the questions that you get on this particular topic.